Hi everyone. So I'm delighted to be here with you all again, and I really missed VMR in this couple of months, and yeah, super excited to be here and present this case for you all. So I'm gonna give you just the chief complaint and a little bit of background information to this first article. This is a 50-year-old female with no chronic medical conditions that came to the ED this morning due to right-sided facial droop. And that's the end of the article.
Holy smokes, at the end of the shift, you're telling me a right-sided facial droop. I have to wake up now. Very concerning, chief concern. So thoughts, what are you all thinking?
I think the first thing that comes to mind is definitely stroke.
I love it, Anna. And the whole point of 30-minute VMR is to try to move quickly, just like the ER. So if you were in the ER and you had this patient, what would be the first sort of initial 1 or 2 minutes that you would try to be doing in that triage room, for example? What do you think?
I would be doing a full neuro exam, checking for any recent head trauma and kind of a quick history, see if there are any anticoagulants and get them off to like a head CT for starters.
Beautiful. I absolutely love that. Your priority is here a vascular issue, and I think that other neurological clues would be very, very informative. I see Richard Williams is also discussing peripheral versus central. Richard, if you're able to unmute and tell us more about that, that would be wonderful. If not, no worries.
Well, just thinking, if it's an isolated face, that's very interesting with nothing on the right side of the body. I'm thinking, well, maybe this is peripheral. Let's just see if that forehead can be wrinkled.
Beautiful, beautiful. And Richard, I think this is the first time you and I are talking directly. Tell me more about yourself.
Ravi and I go back decades.
Yeah.
And I was aware of clinical problem solvers from Reza Manesh when he was here. I'm in Baltimore.
Wonderful.
And I'm semi-retired, but I still enjoy teaching and learning. We have an internal medicine residency here that includes several hospitals. I'm a retired gastroenterologist and also was a program director for 25 years of IM. And I'll tell you, my first MICSAT was 1972. And even though I was in GI, I did MICSAT every year since then. I just love internal medicine too. So that's a little about me.
That's incredible. Your love for internal medicine is palpable. And I might even extend that to neurology here. Well, and it's so nice to meet you. And, you know, this probably, thank you. This probably reflects the grogginess of the night shift. I remember your conversation with Reza live on VMR a month or two ago, and it's really, really nice to see you again. And I completely agree. I think that's the and I don't know if you're seeing this in the chat, you're getting a lot of love from Ravi. So, you know, I'll just say our general principle: whenever somebody is weak, the first instinct is it upper motor neuron or lower motor neuron, no matter where that weakness is, right? And it just so happens that the tools that we use to make that determination, upper motor neuron versus lower motor neuron, change depending on where that lesion is. So if the lesion is in the extremities, we use pyramidal pattern weakness, so distal, predominant, extensor in the arms and flexor in the legs to suggest that it's upper motor neuron. And as is pointed out by many people in the chat, the way we do that for the face is very different. So to be quick, if this patient has involvement of the entire facial nerve, it's unlikely to be an upper motor neuron lesion. So if the patient has both upper and lower face involved, it pinpoints the disease to the facial nerve. If the forehead is spared and only the lower half of the facial nerve is involved, that suggests an upper motor neuron lesion. It's counterintuitive. I won't go over the pathophysiology because that's not the ER style. We have to move quickly, but I will tell you that the more damage you see on the face in a patient with a facial palsy, the more reassured you should be. It's very puzzling. When I was learning this, I learned it in the textbook, but then when I was seeing patients, like, oh, it's so weird that I'm actually reassured to some extent that when there's more problems of the whole face, I should relax. So you kind of have to hardwire that and invert that instinct of yours. So more badness on the surface actually means less morbidity. Now there's a big caveat here. The big caveat is you can actually have a brainstem stroke that knocks out the facial nerve nucleus. So can you have a stroke that looks like a peripheral neuropathy? The answer is yes. If you infarct the brainstem and the peripheral nerve nucleus, you will have a classic Bell's palsy-like lesion. What's the biggest clue? Time course. So I think in addition to what Anna said we should do on exam, the other key question is, what is the time course? And if we went from 0 to 100 over the course of seconds or minutes, this patient needs imaging no matter what their pattern is, because a lower motor neuron pattern would be consistent with a brainstem stroke. Okay, all right, let's hand the mic back to Rafa to give us more data.
Sure, incredible discussion as usual. So let's see. This patient is unable to fully close her right eye, and on the visual systems, she denies headache, neck stiffness, extremity weakness, numbness, but she reports fatigue and low-grade fevers for the past several months. This patient takes no medication. Occasionally, she uses alcohol, and she's sexually active with multiple women. When it comes to the vital signs, these are within normal limits. Do you want a physical exam, or it's a good place to stop?
You know, Rafa, you're giving us a lot of juicy information, and so I think let's take a moment to reflect on it. So I'm just going to pause for 30 seconds to a minute and see what vibes accumulate in the chat, and we'll have folks chime in. So just share whatever thoughts cross your mind, okay? I just want to amplify one big thing that Richard said, which is very, very important. Quote, everything is so crowded in the brainstem, it's hard to get isolated cranial nerve 7 alone. And that fact deserves a lot of emphasis, which means practically for you in the ER, you really have to make sure there are no other accompanying neurological symptoms. If there are, you should worry. If there are not, the probability of a brainstem stroke is very, very low, probably close to 0. All right, y'all, let's see what you think about the second aliquot, and we'll reconvene in about 30 seconds to a minute. Angelita, at least if my memory serves me correctly, I think you're working, but there's just too much wisdom here. Are you able to unmute and share your thoughts? No worries. If not, I'll just read them out loud. Alrighty, I think oh no, you're in front of your patients. Oh gosh. I'll read your thoughts. So you're really trying to localize the lesion. And I think that's super important. Wondering if there's diplopia, blurred vision, facial pain, dysarthria, like you're really trying to understand the nature of this complaint. And let's move quickly like we always should in this space. As soon as we establish that this is a peripheral Bell's palsy, which we haven't yet, but the time course is suggestive of that here. The fact that the patient has had a subacute time course makes it much more likely that this is a peripheral nerve lesion. Although an expanding mass or a demyelinating disease can certainly be central and have a subacute time course. So what does this do? If we are entering the world of peripheral nerve lesion, then the base rate, meaning the most likely condition, would tell you that this is Bell's palsy, right? Bell's palsy accounts for about 70% of ipsilateral lower motor neuron facial palsy. But you have to be very careful because by definition, Bell's meets these few fundamental criteria. It has to be an isolated facial nerve palsy with no other neurological symptoms. It has to be slow in onset and slow in offset, meaning it begins over the course of a few days and slowly gets better over a course of a few days or a few weeks. So isolated, slow, and without any systemic features. Bell's palsy, idiopathic Bell's palsy, using the term strictly, has none of this other associated features. So why is this case immediately grabbing my attention? It is violating the base rate. The base rate of most people who come in with a slowly progressive facial palsy have no other systemic symptoms going on. So those systemic symptoms may be true, and unrelated, but they really up the ante for a secondary cause of Bell's palsy. So before we get ahead of ourselves, I'd love for Rafa to give us the exam to show us what our prediction was. Is this actually lower or upper? And if we get there, I'll share with you an approach to secondary causes of cranial nerve 7 issues. All right, Rafa, back to you.
I'm going to give you the physical exam then. So let's see. This patient HEENG exam is remarkable for enlarged bilateral parotid glands, scattered enlarged cervical lymph nodes. When it comes to the lungs clear bilaterally, heart sounds are normal. When it comes to the neuro exam, which I think most people are interested in, there's flattening of the right nasolabial fold, drooping of the right corner of the mouth, and right-sided hyperacusis. Sensation to touch on the face is normal bilaterally. The remainder of the neurological exam is normal, and inspection of the external acoustic meatus and tympanic membrane shows no abnormalities. And that's the end of the physical exam.
Oh, so good. So good. There's so many amazing thoughts in the chat, and I would love to amplify them. So Ian, you were the first to mention some things that about the sexual history. Do you mind unmuting and sharing those thoughts?
Yeah, no problem. Can you hear me okay?
Yeah, loud and clear, my friend.
Yeah, I mean, at least with related to, viral identifiable causes of Bell's palsy, my mind first goes to HSV1, and given the sexual history, it makes me think about that. Some other people mentioned some good causes as well, but that's kind of where my mind went.
Absolutely beautiful. You're like alley-ooping Anna to share her thought. Anna, do you want to unmute and share it?
Yeah. I was thinking maybe like neurosyphilis.
Yeah.
But I would think more pupil findings like bilateral meiosis, and more like tabes dorsalis, and we don't really hear much about that. But then again, I've heard that syphilis can present very like broadly, like similarly to other diseases, and kind of not be very clear cut. So
Yeah.
that's something I would keep on my radar.
100%. The provider who knows syphilis knows all medicine, and by definition, that is impossible, as you're alluding to. Robbie's adding another infection to our list that begins with an H. Robbie, do you want to share that thought out loud?
Yeah, I was thinking with the sexual history, possibly syphilis is a great cause. Like we had last week, the autosyphilis
Right.
the schema that Reza deployed showed that neurosyphilis can happen at any stage. So just want to mention that. So you don't even have to have any of the other manifestations of neurosyphilis. So like that bilateral hearing loss. But HIV is also a great mimicker, something that we have to entertain with the sexual history.
Absolutely, my friend. We're going to be doing a lot of testing. And Hans is sharing some pathophysiology here. Hans, do you want to share your the most recent thought you had?
Yes, now that we know that probably the entire facial nerve is affected with hyperacusis, which is a little bit different from neurosyphilis, HIV, and maybe secondary HSV would be quite likely. And that might explain the swollen lymph nodes and maybe the parotid gland. So let's see how it is.
Yeah, you're raising such a fascinating point here, which is actually a really important reflection. So I think it deserves a little bit more spotlight. Hans, I would say that the reason I'm taking this to space is you're saying, hey, the parotid is big, and I know the facial nerve courses through the parotid. Could this be compressive cranial nerve 7? I think that's an outstanding thought. That's one of the secondary causes we'll have to entertain. But I will say, yes, Richard, this is an absolutely superb point. Do you mind sharing it out loud for the audience to hear on YouTube?
I love this hyperacusis
Yeah.
symptom, and I didn't want to ignore it. I was trying to think of an explanation. So if you get the seventh before the takeoff of the chorda, then you don't have that ability to tamper sound. And, it can, I think, even be uncomfortably loud.
Yeah. Yeah, it's incredible how a lesion in the neuroaxis produces more symptoms. It's one of those rare issues where because of a loss of function, you have more severe symptoms, which I find absolutely fascinating. Thank you for explaining the pathophysiology behind it. So practically, if we're moving in the ER, you're seeing a patient who has lower motor neuron pattern facial palsy, who you already predicted based on the time course. And here's one key question. How can you make progress right then and there by looking at the face for what may be the cause of Bell's palsy? And let me share with you a note that I haven't turned into a schema, but I will after this. So what are local clues that tell you the cause of Bell's palsy? You guys see the screen under local clues, and we'll turn this into a schema to publish. So you can find the cause right then and there by emphasizing your exam of the face. If you see a big parotid, massive parotid, you might wonder about compressive disease like you would have with an abscess in the parotid or a tumor. It's also really important to entertain a very rare but important cause of Bell's palsy, which is tetanus. And tetanus is on the rise in many parts of the world and actually can cause facial nerve paralysis as the beginning of cephalic tetanus. More commonly, you'll see vesicles, which would suggest Ramsay-Hunt or HSV. We talked about the parotid mass, and here Hans's point is really crucial because parotid enlargement may be true, and unrelated, meaning that you have parotid enlargement that's not compressing your nerves, but is actually linked to the Bell's palsy through a systemic disease. An example would be you have sarcoid causing Bell's palsy and also incidentally causing parotid enlargement. So the dots may not connect directly, but rather indirectly through an underlying cause. Melkinser-Rosenthal is a fascinating syndrome of idiopathic facial palsy, which is recurrent and characterized by a unique appearance of the tongue and very fissured. And then don't forget to look at the eyes. The presence of uveitis might clue you into sarcoid. So what's the point here? If you're moving quickly, know that you should pause to look at the possibility of the answer being revealed on the face in the form of vesicles, in the form of big masses in the parotid, and sometimes even the clue may be in the eyes in the form of uveitis. So it's unusual to see the answer right there with the facial palsy, but you're already looking, so might as well look a little bit closer to try to reveal the answer. Alrighty, Rafa, back to you.
Okay, so I'm gonna give you some labs. Okay, so the hemoglobin of this patient was 13, leukocytes 8,000, platelets or within the normal limits. Her sodium was 141, potassium 3.9, creatinine 0.9, her calcium was 11.5, and her glucose was 100. And I have one more aliquot with imaging and one more with will reveal the final diagnosis.
Ooh. I will tell you that I think Rafa just told us the answer or suggested it very strongly. He's smiling. Yes, Ravi, I think that chain of reasoning is really important. Do you mind elaborating on how you got there?
Yeah, I think you had mentioned before that in hyperparathyroidism, that sarcoidosis, you can have, I think it's the one hydroxylase activity, which with vitamin D that can cause increase in calcium reabsorption. So that could be a mechanism for this.
Absolutely superb. Beautiful. Beautiful. Let me share those causes with you again, right? We said we might get here, and here we are. We're wondering about the possibility of secondary facial nerve palsy, which is only 30%. The reason we bypassed Bell's is because there are systemic, it's unilateral. The timing is okay for it, but it's not isolated because there are other systemic diseases. Now look at this. None of these are associated with hypercalcemia. This is associated with hypercalcemia, as Ravi told us. Compressive disease is still possible. You might have malignancy-associated compression either of the skull base or of the parotid, and that may be at play. But the hypercalcemia is a very suggestive feature that this may be sarcoidosis. And in fact, a very specific presentation of sarcoidosis. If you look closely in the eye and you notice any eye disease, this might be a presentation of what's called uveo parotid fever, or Hereford syndrome, which describes bilateral parotitis, uveitis, fever, and potentially compressive facial nerve palsy in the setting of sarcoid. Why use such a fancy name for this condition? The differential diagnosis of this combination of things is so limited that it's one of the 2 times you may not need to get a biopsy in a patient with sarcoid. Most times you need to prove that there are those non-caseating granulomas, but in 2 instances, Hereford syndrome, which we just talked about, uveo parotid fever, and 2, Lofgren syndrome, which are mirror images of each other. Hereford is upper body, these are swollen, and the facial nerve may be compressive, and Lofgren's, which is the opposite, causes erythema nodosum and ankle arthritis. So literally like splitting the body. And yes, Ravi, I just did a little tweet about instances where you don't need to do a lymph node biopsy, and this came up. So medicine is a small, small world indeed. All right, Rafa, I'll give you the mic back to give us the imaging, and then we'll go home after that.
Yeah, sure. So I guess the imaging will be revealing in a sense as well. So a chest X-ray was performed and showed bilateral hilar lymphadenopathy.
Amazing. And I think just for the sake of efficiency, that supports the notion of sarcoidosis, but it's an opportunity for us to practice. So do you have a sense how often in a patient with sarcoid will you not see hilar lymphadenopathy? Because we get so used to it, right? We almost expect it. I had just learned this number and I'd love to arm you with it. So do you have a sense of, take a guess, anybody in the chat, how often is the patient with sarcoid not have the thing that we wait for them to have? Any thoughts? This is like test taking strategy. 20% or 20%. Oh, I see some very savvy test takers. 20% in a row. All right. It's actually a little bit lower. It's about 5 to 10%. And so you can really hammer it home. If you're the only times where you need to suspect sarcoid and there is no hilar lymphadenopathy is when you have a really high pretest probability of it. So you can really, really drop your anchor and only be wrong 5 or 10% of the time. It's also important to know that bilateral hilar lymphadenopathy does not equal sarcoidosis, that the most important mimickers are pneumoconioses, so things like silicosis and borreliosis, but most morbidly, things like lymphoma. So remember that this could be one of the terrible T's, a terrible lymphoma. And how would you move away from a lymphoma in this case? Ultimately, a biopsy, but the clue may be the time course. So this is a really good time to go back to the patient and be like, when were you last pristinely normal? And if you get an answer that is a days, weeks, you can be pretty confident. And you can be even more confident in this situation because you may not need to treat the patient. The more symptomatic the patient is from their acute sarcoid, the more likely they are to resolve spontaneously without therapy, which is something that is not a feature of cancer. So what I would do is I would cautiously approach this as a working diagnosis of Hereford syndrome or uveitis parotid fever. You might be able to avoid a biopsy if you're confident enough. And you should expect the patient to have complete resolution of their symptoms. If they don't, you might have to reassess your diagnosis. Any questions about that? Do you want to share your, I think this is a wonderful question. Do you want to share your thought out loud, Richard?
I'm still working on the hyperacusis. So if the issue is something with the parotid interfering with cranial nerve 7 function,
yeah,
that's distal to the chorda tympani. Just a thought there. And I think as a general rule of thumb, when you make the diagnosis of sarcoidosis, be sure you do an ophthalmology referral.
Yeah. I think the ophtho referral is really, really important. And the ocular complications can be devastating and easily treatable. The way I would put it together, and it's just a best guess, is This person has parotid enlargement. This person has a cranial nerve 7 palsy. And I don't think it's this. I think that there's an underlying denominator, sarcoid, infiltrating the peripheral nerve at its origin, causing the hyperacusis and also infiltrating the parotid. That would be my best guess. But again, I think the only way you could prove that is if the patient's cranial nerve 7 palsy improves, but the parotid stays large. And you're like, you know what? I've proven that disconnect. Yeah. What did you find, Rafa? What was the case resolution and what was the diagnosis?
Yeah, so we did a biopsy with the lymph node and it showed non-caseating granulomas, which was consistent with neurological sarcoidosis, the cause of the facial paralysis.
Amazing. Sorry, I'm being summoned, but I have a couple minutes. Any thoughts or reflections on this case, folks? I think it's so illuminating. And I would say that before passing the mic to Rafa, who both presented the case and did the teaching points at the same time, I think the highlights are always time course. Time course came up in the beginning when we were like, no matter what a facial palsy looks like, if it's abrupt in onset, we have to respect the CNS. And at the end, when you're trying to distinguish between sarcoid and lymphoma, the time course. It's hard for lymphomas to be isolated and acute. And the more long-standing the symptoms are, the more concerned you should get. So always pay attention to the time course. I think is very illuminating. All right, Rafa, do you want to do our teaching points? Take us home?
Sure, I think I can share the screen. Or Harry, could you share the screen, please? So we started the case with right-sided facial droop, and we thought about first peripheral versus central causes. There's this thing that you have to remember when dealing with facial droop. Upper and lower hemifacial, when they're affected, you have to think about peripheral causes, and usually these patients don't have other neurodeficits. If it spares the upper face, you have to think about central etiologies, think about, for example, stroke. And because there's bilateral innervation of the upper head, so the upper face is spared. Caveat could be in the setting of midbrain stroke. So we talked about the full neuro exam, history, head CT is very important here. And the pearl that Rab shared with us that the most common unilateral facial weakness cause is actually Bell's palsy. But to think about Bell's palsy, there has to be no multi-system involvement, has to be isolated with slow onset and slow offset. Basically, it's a diagnosis of exclusion. And this patient had fever, fatigue, so less likely to be Bell's palsy. So we thought about secondary etiologies of facial droop. We thought about malignancy, like parotid cancer, infections like herpes zoster, Lyme disease, granulomatosis disease, like sarcoidosis, and neurological etiologies as well, like stroke and GBS. So when we combine the hypercalcemia and the facial palsy, we thought about sarcoidosis, that is granulomatosis disease with macrophage activation. The alpha-1 hydroxylase, 1-alpha hydroxylase is actually activated, leading to the activation of vitamin D and leading to hypercalcemia. And also, Rabbi reminds us that if uveitis is seen on the physical exam, would be another clue to a sarcoidosis. And just a pearl that 10% of patients with neurological manifestations with sarcoidosis. Other neurological manifestations besides the facial droop could be central DI and seizures. So thank everyone, such a nice discussion, and hope to see everyone tomorrow.